Well, thank you again. I really appreciate the opportunity to come to this prestigious meeting, to have such a wonderful array of participants from all around the world. And so congratulations. I don't have any
Can you speak a
conflicts.
little bit louder? A little bit louder?
Okay, can you hear me?
Yeah.
I don't have any conflicts of interest other than to say I long for the days when we all could be together here as myself and Raul here in downtown Cleveland when in 2019 when we had the opportunity to host the annual ASCRS event, and we had the wonderful time with me and my wife to go out to dinner. It wasn't Brazilian steakhouse. I felt bad that I took them there, but I can tell you it was wonderful what time when we had all friends together. And so just talking a little bit about this, I always like to go back to the history. I think it's very interesting is that when you look back at Lynch, really the first description of this entire process of family with inherited intestinal cancer was family G after Germany by a pathologist at the University of Michigan. Gastric cancer was felt at that time to be the kind of the predominant cancer, but colorectal and uterine were also noted. Really, Lynch was after Henry T. Lynch at Creighton University at the time, came up with family N after Nebraska. Creighton is in Nebraska, and then family M out of Michigan, that he noticed striking similarities to family G. And it kind of went on from there. There was actually, he was banned at a certain case when they thought that he shouldn't have it be, it was unbelievable thought at that time that cancer would be inheritable. So it's important when we talk about this debate of segmental versus extended resections to really go back to the epidemiology of this and realize we are talking about a minority of patients in here. And really, when you talk about the idea of when these patients are, it does go into our counseling of the patients when they develop it to say, what are we going to be able to do with these patients? And at what level? Are they on the early side, in their 40s, or in the later side, on their 60s or beyond? And then that has to weigh into our counseling in terms of what is the type of resection that we're going to do. It is important to understand that there is an accelerated carcinogenesis. When we talk about 2 to 3 years compared to the traditional 4 to 10, we have to keep that in mind. And then really to go into what type of tumors are we talking about. And as emphasized by the case that we talked about earlier, the reality is that about 70% of the tumors are right-sided. So when you see somebody who has an isolated left-sided lesion, you have to say to yourself, is there a right-sided lesion lurking, especially like in this case where they weren't able to clear the rest of the colon? We talked about that. And what is the increased frequency of synchronous lesions? So having a segmental versus an extended, you have to take these into consideration. And I surely hope I don't run into Dr. Lopez's talk as a part of my talk. So, we talk about the genetics, and this is the other aspect that is emphasized by the cases. What are we dealing with? Are we dealing with an MLH1 or an MSH2 lesion, which are about 80% of the cases of Lynch syndrome and the traditional clinical features? Or is this an MSH2 lesion, which they tend to be later onset? So if you have these two type of lesions, maybe your ideas about the extent of resection will be different compared to one versus the other. In addition, the MSH6 lesion, is that going to be a little bit different? Because we know that the cancer risk for individuals, when we're talking about an older patient population, may differ as you talk about what is the actual genetic defect. To kind of dovetail on our last talk, getting that genetic defect out there may again be able to say, you have a higher risk of developing colon cancer, as you can see right here, a high risk of synchronous lesions, depending on what that is. And then what age in life are they at? So we can't just necessarily say that we're going to do one size fits all. And I encourage everybody to think about Lynch and then think about the genetic defect and then apply that to the patient in front of you to be able to say, what is the treatment that you're going to propose? You can see all sorts of algorithms that are out there for patients with Lynch, segmental, extended, and you'll see nice diagrams and they can correspond to textbook chapters. But the reality of the situation is you have a patient in front of you. And so you have to take in multiple factors into consideration when planning for surgery. Is there, or do you even know if there is synchronous pathology? That's obviously going to play into it. What is that risk of metachronous colorectal cancer? And I'll go into that. Look at the patient in front of you. Are they 70 years old? Are they 40 years old? What is their life expectancy and what is their disease prognosis? Is there something else? Is it a stage 4 patient? Is it a stage 1 patient? Think about the case that was applied to us at hand. that on the one case, they had a T1 lesion. The other patient had a T3 lesion. So you have to take in what the disease prognosis is when each of them. And then is this a patient, if you're saying that you're going to do surveillance on them, do you think they're actually going to follow up? I can tell you that in many cases around here in Ohio, there's going to be certain places and that we know patients really don't come back to the doctor much. So if you're talking about surveillance and they're not going to come see you, then maybe you should do an extended resection. What is the morbidity of those patients? You know, what is their comorbidities? Are you worried about functional outcomes? And of course, we have to talk to the patient about their preference and their quality of life. Segmental colectomy in and of itself has a risk of developing metachronous lesions. And yet these are the baseline numbers that I encourage everybody to remember. So when you talk about segmental versus extended, metachronous lesions for colorectal cancer are listed here, and obviously they increase with the more years that go out. It's also important to understand, and I think that Professor Lopez is going to talk a little bit about this, but understanding the concept that extended colectomy is by and large a prophylactic measure that you're going to remove more colon than you would. And the goal is to hopefully by removing that colon, it's no longer at risk. Why? Because it's down in pathology. It's no longer a part of the patient. So you're hopefully reducing that metachronous cancer risk over this guiding principle. It's also important to understand that we don't have level 1 data that we can look at to be able to say one is better than the other. What we do know is that if you do have some life expectancy data that's published out there that talks about there is some life expectancy, whether you're age 27 versus 47 versus 67, and this goes back to what we were talking about before in terms of what is the disease state, what is the patient's age that they're at when they're diagnosed with the initial primary lesion. If you look back, there's the U.S. Multi-Task Force Society that talks about what their recommendations are. And they say that colectomy with ileorectal anastomosis should be the primary treatment for Lynch syndrome with colon cancer that's not removed by endoscopy. And they bring age into it, or somebody that has problems associated with functional defects for consideration for less extensive surgery, i.e. a segmental resection for older patients and those with underlying sphincter dysfunction. So the current guidelines are essentially a total colectomy with an ileorectal for a person who has colon cancer, or those patients that have significantly affected by bowel function. Maybe you can do the other. The last one from ASCARS, of which I was, full disclosure, chair of the committee, talked about what it is for colon rectal cancer. And so for individuals, again, for Lynch syndrome with colon cancer, the total colectomy is the preferred risk, and a segmental may be considered, despite the decrease in cancer risk reduction, essentially, again, going back to function. So patient preference, function, quality of life, and a reduced overall risk. And what is that? So now we got to take a turn a little bit and say, what is the risk if you do this of having it occur in the rectum? And that risk, as you can see right there, is roughly 5 to 10% at 10 years. So these patients need to undergo surveillance. Let's flip the script a little bit and talk about what do we do with a patient in terms of developing a rectal cancer. So now you have a rectal cancer primary. What is the risk of metachronous colon cancer? Because remember, we're talking about the vast majority of this being the colon that's at risk. And that risk goes up substantially as you get into 10 to 20 to 30 years. And you can see upwards of 70% at 30 years. So for rectal cancer patients with Lynch, this is what we talked about during that case, the high risk of developing metachronous colon cancer. The risks and benefits of taking it all out and doing a pouch should be discussed with them for those patients where you're undergoing a curative procedure. And in general, there's no real changes regarding the oncological principles. There are still patients, as Professor Cutait said, about there's arguments out there. So for some people say extended colectomy, your interval cancers will develop in 35% under colonoscopic surveillance. So even if you undergo surveillance, they'll still occur. And this could be from poor prep or compliance issues, or the endoscopist misses it. Or maybe it's just that aggressive or faster colon carcinoma sequence that occurs in Lynch patients. Those people who say you shouldn't do that against the extended colectomy, talk about the fact that, yeah, you can say that there's 35% that can occur, but if you do a good and proper, and the patient is compliant, and you have a good bowel prep, that you can identify these lesions early and you can take care of them endoscopically. Furthermore, taking out an entire colon, especially in an older patient, does have some functional problems associated with it. And as we talked about, there is a risk of rectal cancer developing with an ileorectal, so you still need to survey the rectum. Surveillance, we all know about surveillance and screening, and we can see there's lots of charts that talk about what you should do with these lymph patients, but despite adequate surveillance, they still can occur. So in final, there are considerations for segmental. If they're unhealthy, they can't tolerate the extended resection, or let's say that there's somebody who has underlying renal disease that you worry about dehydration going into full-blown kidney failure, that's a problem. Those patients who have a limited life expectancy, especially when you have obstructing lesions like we saw in our case 3 here to start off this session, those that have stage 4 disease. And finally, we got to go back to our patients and say, what is your tone like? Are you going to have functional issues? What is your preference, and what is your compliance going to be like? So in summary, we should use mutation-directed analysis as a part of our decision-making process for determining an extended versus a segmental colectomy, and make sure that your patient and you, the provider, understand that whether you choose total or subtotal colectomy or total proctocolectomy with a pouch, understand the risks and the need for surveillance. Thank you very much.